Ladies and gentlemen, once again, please welcome your HOPA president, Susanna Kuhn.
Good morning, everyone. Thank you for joining us for this very special lecture. As many of you are aware, the John Kuhn Lecture was named after our founding father, Dr. John Kuhn, out of San Antonio. We are very thrilled and honored to have our guest speaker, Dr. Ross Camage, here with us today. Dr. Camage, he's a professor of medicine and oncology, and he holds the Joyce Zeff Chair in Lung Cancer Research at the University of Colorado. He received his PhD from Cambridge University in 1995, and prior to that, he received his undergraduate degree at Oxford University. Dr. Camage joined the University of Colorado as a visiting professor in November of 2005 and was recruited as a full-time faculty in October of 2007. He is the director of the Thoracic Oncology unit at the University of Colorado, and his focus is in thoracic malignancies and developmental therapeutics. He is also the National Medical Director of the Academic Thoracic Oncology Medical Investigators Consortium, affectionately known as ATOMIC. He has won numerous awards, including in 2012, he was the recipient of the Bonnie J. Adario International Lectureship Award as a luminary in the quest to eradicate lung cancer. Most recently, in 2017, he was recognized as a highly cited researcher in Clarivate's Web of Science, ranked among the top 1% of clinical medicine researchers internationally. Dr. Camage has been the principal investigator on numerous clinical trials and early phase drug development on thoracic malignancies, and his work has been repeatedly helping to change the standard of care in the treatment of lung and other thoracic cancers. So I'd like to welcome Dr. Camage to the podium.
Thank you so much. Thanks for inviting me. Thank you. We have no photographer. Oh, we have a photographer. It wouldn't be the same without the photographer. Okay. Thank you. Thank you so much. This is actually very exciting for me because I think they've done a survey that the most trusted people are actually pharmacists. So to actually get an award from pharmacists means a lot. Okay, so I am going to talk to you for about 40 minutes. But we're going to warm you up intellectually with some audience response questions. So as soon as I think you can vote any time now, that green box is there. I'm going to read the question to you, but vote as soon as you feel comfortable. Only one of these is not true, so you have to pick the one which is not true in relation to oncogene-addicted non-small cell lung cancer. Osimertinib is the preferred first-line EGFR TKI for advanced EGFR mutant non-small cell lung cancer per the National Comprehensive Cancer Network. TAPOs, and if you don't know what they are, you're going to find out. TAPOs are a recognized complication of osimertinib. Alectinib, brigatinib, and ceritinib are all licensed for use in advanced ALK-positive non-small cell lung cancer post-crizotinib. Brigatinib's recommended dosing starts at 90 milligrams for 1 week and then dose escalates to 180 milligrams if tolerated. And the dose reduction rate for 450 milligrams ceritinib with food is 10%. Vote. Do you guys all know how to vote? Okay, good. It's not working? Do you want me to just tell you the answer? Okay. Well, I think the lecture is going to be more important than the question, so let's just skip. Here we go. There's the question. There's the answer. Okay, you've forgotten what the questions were, weren't you? There we go. Okay. So the osimertinib is not the preferred first-line treatment by the NCCN, and you're going to find out why. The key word is the magic word preferred. Okay, question 2. Which of the following is not true with regard to PD-1 or PD-1-directed therapy for non-small cell lung cancer? Higher PD-1 protein expression is associated with greater benefit from these agents. Carboplatin pemetrexed and pembrolizumab is a first-line option, that should be option, not open, for EGFR and ALK wild-type non-squamous non-small cell lung cancer. OS, overall survival benefit, exceeds progression-free survival benefit in most second-line trials of these agents. High PD-L1 EGFR mutant lung cancer should receive pembrolizumab as first or second-line therapy either before or immediately after an EGFR TKI. Salvage chemotherapy outcomes post-PD-1 or PD-L1 therapy may be enhanced compared to in PD-1 naive patients. Again, only one of these is not true. Voting still not working? Okay. It's good to know we're starting off in a good... Okay, so the correct, well, I guess the one incorrect answer, you ready, is D. Which one was D? It's about high PD-L1 in the setting of a mutation. And again, you will see. Okay, so let's get on with the talk. All right. There will be drugs. Lessons learned. This is actually, as of like yesterday, totally by chance, now available on Amazon Prime for free. So you can go home and watch this. Not my talk, the Daniel Day-Lewis movie. So the key thing is, so any monkey can give you a review talk. The key thing here is we're going to talk about lessons learned. So that if lung cancer is something you never treat, but occasionally are aware of, I want your brains to be thinking about how you can extend the lessons that we've learned here, to other tumor types. These are my disclosures. So this is one of my favorite quotes. Every generation needs its own revolution. And in lung cancer, we've had two revolutions in recent years: personalized medicine and immunotherapy. And almost as the dust was just settling on the first one, the second one arrived. And they have acted as if they're independent. But they're not. They are starting to clash heads. And that's kind of a hint to that question that we asked about, what do you do with somebody who has high PD-L1 and an oncogene? Let's start with personalized medicine. So you guys already know that. So in terms of FDA-approved molecularly specific drugs, we now have EGFR, ALK, ROS1, and then most recently from June of last year, we have BRAF V600E mutations. That's about 2% of lung cancer, are licensed for the combination of dabrafenib and trametinib. And at least until we started getting to immunotherapy, everything else was lumped together, and you got some kind of platinum doublet, depending on exactly what your histology was. But there are others coming. Okay? And I think one of the problems is, particularly for a very busy general oncologist, your source of information is people who have a drug to sell. Okay, so they're going to be told that they should test for ALK, EGFR, ROS, and BRAF. And if they're not testing for those four, then at least that's something you can improve their education on. But that is just the start. And there are multiple other molecular abnormalities which are targetable. So this is data from the Lung Cancer Mutation Consortium, which looked for about 10 different abnormalities in 1,000 adenocarcinomas of the lung. You can see in the blue box there's EGFR, in the purple there's ALK, and a few others in there. BRAF is in the blue bar somewhere at the top. But one of the key things that we found out from this is down at the bottom left, is that they found one of these abnormalities, even within their fairly restrictive list, in more than 50% of cases of lung cancer. And importantly, 97% of these were mutually exclusive. These are fundamentally different diseases. So what else is likely to become licensed, or if it was your mother diagnosed, that you would want to know about, because there might be a drug either in the clinical trial that has activity, or that you could jerry-rig something that's just sitting in the pharmacy? And so that's the black box here. And I've split it into two columns, depending on whether the response rate that's been reported is greater or less than 40%. Now, why 40%? Because you're trying to decide if this is something that you want to wait for the result on before giving them platinum doublet chemotherapy. Okay, if it's less than 40%, the platinum doublet's more likely to work. If it's higher than 40%, like the ALK, like the ROS, like the BRAF, then this is something that if the patient is fit enough, both mentally and physically, to wait, they should wait for that result. So what's sitting in the greater than 40%? NTRK gene rearrangements, MET, very high-level MET amplification. So MET is very confusing in terms of how it's described. You can have increases in the copy number of MET, which is just something called high polysomy, which has nothing to do with driving the cancer, but it's really when the MET is amplified relative to the rest of the chromosome. And at least in my hands, the best way to do that is looking at the MET to centromere ratio, and that has to have a ratio of 5. Maybe at ASCO, we're going to see it's down to about 4. I'm going to explore, in terms of the stuff in less than, MET exon 14 mutations, or work in progress HER2 mutations. I'm going to show you one example of just sort of some of the work that's going on, and that's with RET rearrangements. Now, you've heard the term rearrangement. ALK is an ALK rearrangement. ROS1 is a ROS1 rearrangement. NTRK is a gene rearrangement. This is where you have a gene which is usually involved in developmental processes, which is silenced in most adult tissues. And it gets turned on because the cancer hijacks a normal gene. It takes a normal gene that has a promoter that's functional in the lung tissue and a little bit of the 5' part of that gene, and then attaches it to this otherwise dormant but very potent oncogene. And now suddenly you have a fusion gene and a fusion protein, and that's what's driving the cancer. Normally, the fusion partner didn't matter. Okay? It just could get a functional promoter. But it turns out it does matter for RET. So KIF5B is one of the fusion partners, and then there are other non-KIF5B fusion partners. And last year, we saw this is data with a drug called RxDX105. And if you see in this waterfall plot, the red bars are what happens when you give their RET inhibitor to somebody who has a non-KIF5B gene rearrangement. And the blue bars are what happens if you have KIF5B. And the problem is KIF5B is about 2/3 of RET rearrangements. So what's going on? Still trying to figure it out. There are two theories. One is that KIF5B just has a very strong promoter, and so you're just getting a big push of that oncogene, and if you have a kind of modest RET inhibitor, it's just not good enough. The other is that that fusion gene brings with it some other signaling pathways, and one signaling inhibitor isn't going to be enough. Certainly some of the more potent and specific RET inhibitors, so from a company called Blueprint, Blue667, and from Loxo, 292, are starting to report responses with monotherapy in KIF5B rearrangements. So maybe the first theory is looking a little stronger, but we're going to wait and see. Okay. What about the fact that we have these treatments, go on them, everybody feels great, but it's not a cure. Okay, that's the cure for those who are alive in the 1980s. But it doesn't cure people. And in fact, there's almost a median progression-free survival ceiling for many of these first and second generation drugs. So you can see for the EGFR inhibitors, for EGFR mutant, it's running about sort of 8 to 15 months. For the ALK, it's running about 8 to 11 months. Two things are going on. The first is biological resistance. So think about Darwinian evolution. So there's heterogeneity in the cancer, there's diversity within it, and the environment is the drug. So we're in the Galapagos Islands with the finches, and we are selecting out variants that can survive in that environment. And we can group those variants into some very simple bins. So the first thing you can do is you can alter the target for the drug. Either you mutate it so the drug doesn't bind as tightly, or you make more of it. So in the case of EGFR and ALK, for example, amplification of the aberrant gene is an early stage in resistance. The other thing you can do is that pathway is completely suppressed, but the cancer now essentially selects out another oncogenic pathway that can work with it. These were normally called second drivers because they coexisted in the same cell, but we have now seen examples where that mutual exclusivity rule breaks down. So we can even see situations where somebody started with one oncogene, they're on a drug that's effective, and then when you rebiopsy, you can't find that oncogene, and they have a different oncogene. And what we believe is going on there, which was heresy when we first described this a few years ago, is at some point you get two drivers in the same cell, and then you get non-disjunction. The cell divides, and one oncogene ends up in one cell, one oncogene ends up in the other cell, and it can actually have a life of its own. That's rare, but that's called a separate driver. So how do we treat this? Well, as we understand about how the cancer adapts, we adapt with it. So this picture is Hercules wrestling Proteus, who was the shapeshifter. This was one of the 12 tasks of Hercules. So as he changed shape, Hercules adjusted his wrestling hold, and we have to do the same thing. So this is an example from EGFR mutant lung cancer. 60% of people on first or second generation inhibitors develop T790M, another EGFR mutation, so we alter the target of the drug. And osimertinib works on the original form and T790M, and this is a waterfall plot from in the T790M positive patients from the AURA2 study, and actually this is the AURA1 study, and it had a 60% response rate and a median progression-free survival of about 9 months. Some of these drugs are getting licensed so quickly that the rule book in side effects hasn't fully been written by the time it lands in your pharmacy. And so new things will emerge. Not all of them will be in the label. The FDA is very tight and says, if you didn't generate this data within that clinical trial, it may not go in there. So there'll be other stuff which is just out there in the literature which you may not know. So this is TAPOS. TAPOS stands for transient, asymptomatic, pulmonary opacities. What those bars are individual patients, and they're on osimertinib, and every time they get a black arrow, they get a little ball of fluff in their lungs, like the red arrow on the right-hand side. And every time there's a different colored arrow is where that little ball of fluff disappears all by itself. So that's where the transient comes in. They're asymptomatic, they show up in the scan, the patient doesn't have any symptoms at all, and pulmonary opacities because they're little balls of fluff. Now, why does that matter? It matters because it's not progression. Okay, you don't need to treat that with radiotherapy, you don't need to take them off the drug, you don't need to add in chemotherapy. And also, it's not pneumonitis in the sense that it doesn't mean the patient is suddenly going to end up in oxygen in the intensive care unit. So you have to be very careful. In the original study, these were described as grade 1 pneumonitis. In the design of the study, if you had any grade of pneumonitis, you had to come off the drug. So what the investigators did was they stopped calling it pneumonitis. And we called it TAPOS instead. In terms of adapting, the other area is the ALK inhibitors. We have a wealth of next-generation ALK inhibitors. We now have ceritinib, alectinib, and brigatinib licensed. Given post-crizotinib, they all have about the same response rate, about 50 to 70%. So that sounds great. But where they differ is in the duration with which they can control the disease. And it's astonishing how reliable it is across trials. If you look at ceritinib post-crizotinib, across 2 different trials, they're within a month of each other, the median PFS, 5 or 6 months. Alectinib, there's actually now 3 trials where this is within, a month or so, and it's all about 8 or 9 months. And brigatinib has had 2 trials, and it's about 15 or 16 months. So why do they differ? How can the response rate be the same but the PFS different? We assume that the response rate is driven by the common spectrum of resistance mechanisms you get when you walk through the door. So if these drugs can all work on all of those, the response rate is about the same. But if they differ in terms of their ability to control rarer mechanisms of resistance that might emerge next week or next month, that's where the PFS differs, and/or their ability to control disease within the brain. One of the really interesting things which might emerge is only some of this can you explain by penetration into the brain and activity against the range of ALK resistance mutations. I actually think that some of these drugs also have other non-ALK activity which may be contributing to their differences in PFS. And I think that will come out over the next year or so. The other interesting thing about brigatinib, and I'll focus on this just because it's the most recently licensed drug, is dose is important. So the dosing is you start at 90 milligrams for a week and then you go up to 180. Why do you bother going up? Because it's more effective at 180. And we'll come in a second as to why you don't just start at 180. Median progression-free survival at 90 milligrams is 9 months, 15.6 milligrams at 180 milligrams. So dose becomes important. Why? Well, these are some of the resistance mutations. Again, this is only part of the story, but some of the resistance mutations in crizotinib and ALK. You can see on the right-hand side, the dotted line is the predicted exposure at 90 milligrams of brigatinib, and the solid black line is the predicted exposure at 180 milligrams. And you can cover more mechanism resistance at the higher dose. Now, for many of those drugs, that doesn't matter because you move up and down within the dose, and things are all still way above it or way below it. But just for some of the mutations with brigatinib, they're on the cusp. And so dose does seem to matter. What about side effects? Well, you can line up ceritinib, alectinib, and brigatinib, and they have somewhat different side effects. I talked to somebody the other day that, as these drugs get licensed, they probably need to do, those taste tests that they do for Pepsi Cola and Coca-Cola, and they really need to ask the patients which ones they prefer. Because this is an abstraction of reality, what goes into a table. Perhaps the easiest way of, dumbing it all down and saying, well, which is the best tolerated is you can look at the dose reduction rate. But you have to remember that the dose reduction rate is generated from a clinical trial, where the clinical trial may have specific rules. It may say if your CPK goes up, you have to reduce the dose of the drug. Whereas in the real world, if the patient has no symptoms, you probably wouldn't do that. Nevertheless, if you look at them, the standout problem child was ceritinib. at the standard dosing of 750 milligrams without food, with a 60% dose reduction rate. Alectinib and brigatinib about the same. I'm going to show you just a little bit of information focusing on what ceritinib has done to try and control that. And then just, again, because it's the newest drug, I'm just going to focus on one of the potential problem areas with brigatinib, which is the pneumonia, pneumonitis kind of issue that's associated with it. Okay, so let's start with ceritinib. So are we now wiser, hence the owl, and should we having our patients take a nice low-fat mouse before they have the ceritinib? So they did a study called ASCEND-8, where, again, this is such a competitive field. The trials went on so quickly that instead of going through a formal food effect study, they just got their drug licensed, and it kept people alive, but they kind of missed out on some of the details that you might have done in slower development in terms of seeing if you took it with food. In the real world, taking it with food actually makes the drug much more tolerated, and they eventually did the formal study. So taking 450 milligrams with a low-fat meal has very similar pharmacokinetics to the initial licensed dose of 750 milligrams, but much better tolerated. Dose reduction rate now down to about 10%. Although the PK is comparable, we don't technically have short and long-term efficacy to know that that's going to be the same. Is that enough? Have we already had an unpleasant experience with ceritinib and this isn't going to change anyone? It kind of depends. Some people like the drug, and so this is just a better way of using it. What about that pneumonitis issue with brigatinib? So there's a nice study that looked at numbers of treated patients with different ALK inhibitors and the frequency of lung adverse events. And if you look down on the bottom row, the standout problem child was brigatinib with a 7% rate of pulmonary adverse events. But what is actually going on here? Well, they're called EOPS, not TAPOs, EOPS, early onset pulmonary events. And they're different from your classical TKI-related pneumonitis. Okay, we might call it pneumonitis, but it's different. And how is it different? One, it's very rare. 7% is for all grades. Severe grades are probably about 3%. It's rapid onset. If you warn a patient about this, it is still in their short-term memory if they're going to manifest the side effects. It usually happens on the same day or the second day that they get the dosing. From some analyses which are in press, it may be associated with the starting dose, which is why there is the step-up dosing with brigatinib. You can sneak up on it and get through the side effects without anyone noticing it if you start at 90 milligrams. Since they all happen early, if you haven't got it by the first week and you go up to 180, nothing bad happens. It's also possibly related to age. It's possibly related to time from prior crizotinib. Again, these are small, because these are rare, you see patterns that may or may not be there. As mentioned, there is a range of severities. And I think one of the really interesting things is the fifth bullet point, just to prove that this isn't your classical pneumonitis, is you can stay on the drug and it gets better rapidly. Now, that isn't written in the label because they're scared, but I'm going to show you an example of how you can do it. So this is a patient who started on, I think they started on 180, and within 2 days, they became short of breath. And we panicked, and we took them off the drug, and we put them on steroids and oxygen, and everything got better. And then there had been these anecdotal reports of people coming in saying, well, I got a little tight in my chest on the flight home, but I didn't bother telling you about it, doctor, and then it got better. So there was this circumstantial evidence of maybe you could tolerize rapidly to it. So we took this guy, and we convinced him to be a test pilot. We said, we're going to put you back on this drug that made you really unwell. And he's going, okay, doc, bring it on. And so it was over a Labor Day weekend about 3 years ago, and I had him on the steroids. He had oxygen at home, and I phoned him every day. And I gave him an oxygen saturation meter. And what you can see in that graph there are his oxygen saturations over 5 days from restarting the drug. And the diamonds are his oxygen saturations on room air at rest, and the squares are his oxygen saturations on room air on ambulation. And what you can see is day 1, he's fine. Day 2, he's starting to drop when he ambulates. By day 3, there is no ambulatory oxygen saturation because he can't get off the couch. And his oxygen saturation is on room air at 84%. Now, he's got oxygen. He just took him off to get the reading. He stays on the drug, and by day 5, he's off the oxygen. Okay? I have no idea of the mechanism of this. And he stayed on the drug, had a complete response for 3 years. And you can see that's a CT scan, you can see these little fluffiness. He's got a little bit of pneumonitis in it. Should you do that for everybody? No. If your patient is dying, that's not a great thing to do. Okay? But if somebody you feel could tolerate this, so if you can get those supportive care on oxygen, steroids, you just need to know if they can tough that out for 5 days, then they're golden. Nobody from Takeda is going to tell you that. Okay, other mechanisms of acquired resistance. Pharmacological, so biology of the cancer can change. The other is you just can't deliver the drug to the target. And the most common example is progression within the brain. And the brain has really emerged in lung cancer as an important battleground because it's such a high frequency of brain metastases in this disease. So how do we adapt? Well, we have drugs that can get into the brain. It's a combination of a greater proportion of the drug getting into the brain, and maybe those drugs are also more potent, so they do more bang for the buck when they're up there. So we're starting to see data presented where our efficacy is just within CNS lesions. It's very exciting. We're kind of changing the way we present data. So this is a waterfall plot, again with osimertinib, but this is just shrinkage in untreated CNS lesions. And we can see a 70% response rate. And we can see a CNS duration of response of 9 months. We can also see for ALK in the table that we're also seeing CNS response rates and CNS PFS and CNS duration of response being presented. Now, there were some guidelines published in about January that start to really explain how this should be done. Some of it was just done retrospectively, and I think we're going to get much tighter data that we're going to be able to compare across studies. Some of the kind of rookie mistakes we made were not documenting who actually had radiotherapy to the brain or not, and if they had SRS, was the lesion you're calling a target lesion the one treated with SRS or not? So we're just going to get better at that. So where's the future going? Well, we can keep adapting. I was very excited because I wanted to look really smart here. I found a woodcut of Hercules fighting the sons of Proteus. I didn't even know he had sons, but now makes me look really clever. So we keep adapting. This is lorlatinib. Lorlatinib is a so-called third-generation drug, and it is pushing for an FDA license, quote unquote, of post 1 or more ALK tyrosine kinase inhibitors. The FDA is committed to give an opinion on this by the end of August this year. Now, doesn't that maybe approve it? Maybe they'll tweak the wording of the label. Maybe they'll reject it. But I think we're fairly confident there's something going on with lorlatinib. Again, here's some data. This is data in people who've had 2 prior ALK tyrosine kinase inhibitors. We have an overall response rate running about 40%. On the right-hand side, we have that intracranial response rate, because we're starting to show that data, where that's actually running higher at about 48%. In fact, we're now actually in the situation where drugs given in later lines of therapy are actually having a higher response rate in the brain than overall, and the overall data set contains some CNS data. So the extracranial data may be even lower. So now we're getting hyper-responsiveness in the brain. Why? Because the brain is acting as if it's an earlier line of therapy. It's been underexposed to lines of therapy. So this is going to be an interesting drug. It has some tolerability issues associated with it, but let's wait and see whether it gets licensed and then take it from there. What about osimertinib? Just like we have pie charts of mechanisms of resistance to first and second generation drugs, now we have pie charts of mechanisms of resistance to osimertinib. And some people would say, you progress on osimertinib, you have to go to chemotherapy. No. There are still some targetable abnormalities. The first thing that we identified was a third EGFR mutation called C797S. And there was a little bit of excitement, maybe about 12 months ago, about whether it occurred what was called in cis or in trans with the T790M. So that means that you have one set of clones that had your original EGFR mutation in T790M, one set of clones with your EGFR mutation in C797S, so that's in trans, or were all 3 in the same cell, that's in cis. There had been some preclinical work that if they were in trans, you could be on the osimertinib for this, and you could go back on erlotinib or gefitinib for this, and you could combine the two. They've done that, but the duration of benefit is weeks before they all end up in CIS. So it's more a theoretical thing than reality. What they're trying to look at in that group is, sure, people are trying to make drugs that work on C797S. People are also looking at clinical trials where you add in an EGFR monoclonal antibody like necitumumab or cetuximab, and there are clinical trials going on with that. Probably the most actionable abnormality is MET amplification. That thing that could be a primary driver can also be a secondary driver. And we published, actually about a year ago, so Emily York is now in PA school in Utah, but she wrote it up. We had a patient who progressed on osimertinib. His T790M was still suppressed. He had clear high-level MET amplification, and we added in full-dose crizotinib to his full-dose osimertinib, and he responded for another 9 months. So there are targetable abnormalities, and your docs may not know about this. So that's why you're so important. Okay, now people always talk about being, reactive and proactive. Well, we're trying to do the same thing in oncology. So everything I've just talked about is being reactive. Cancer changes, you analyze it, and you go on to something else. The field is now moving in a proactive way. Rather than reacting to resistance, what if we suppress it from the get-go? Rather than a rapid deployment force to go suppress that skirmish going on in part of your body, what if we have an army of occupation that stops the resistance from occurring in the first place? And so these drugs that work on the original forms and the resistant forms, what if we use them up front? Now, this you could draw on the back of a napkin about 5 years ago. And we're going to use this to try and interpret the difference between alectinib as a first-line drug and osimertinib as a first-line drug and how the NCCN viewed those. Okay, so let's imagine drug A here is crizotinib. Median progression-free survival, first line is about 11 months. Drug B is whatever your next-generation drug you want to do, but let's call it alectinib here. And that post-crizotinib, we know alectinib has got about 8 or 9 months median PFS. So if you went on the alectinib first, and you just beat crizotinib, but not by very much, people would go, yeah, so what? I'll still give sequential. The sum of my blue and green arrow is going to be longer. If the alectinib up front was exactly the same as sequential therapy, you'd only care if the drug was cheaper, which it's not going to be, or better tolerated, or, just because you wouldn't have to think so much. You could just go on one drug and you'd put off having to make a decision for, a period of time. But what was really exciting was, could you change the natural history of the disease? If you went on something that actually suppressed resistance from occurring and suppressed the turnover of the cancer more, would there be less diversity within the cancer, and therefore your time to the next mechanism of resistance would be longer? And that's what happened with alectinib. So alectinib, the clinical studies were called the ALEX suite of studies. AL from alectinib, X from Xalkori. If you remember, alectinib was originally a Chugai drug, so there was a parallel Japanese study called J-ALEX, which read out because it had an interim analysis, and then ALEX read out last year. This is the primary endpoint, which was progression-free survival. Normally progression-free survival by the investigator was a bit more optimistic. So usually the independent review committee is always a bit more modest, but for some reason they got away with making the investigator one the primary endpoint. I'm going to show you, that's the investigator assessed one, but in the box in the kind of middle on the right-hand side is actually the IRC assessment. And you can see that the crizotinib, like in every other study before, has a median PFS of about 11 months, but the alectinib is nearly 26 months. Okay? Remember that algebra equation we were doing? So 11 plus 8 or 9 is about 20. This is 26. Are we changing the natural history of the disease here? That's what people think. And that's why the NCCN listed this as the preferred first-line ALK TKI. Not just listed, this is the one you should go on. Now, what about all those other kids out there, ceritinib, brigatinib, lorlatinib, and there's another drug from Exelixis called, Xcoverate called ensartinib. Some of those had licenses which are post-crizotinib, and now nobody's using crizotinib. There are clearly people still on crizotinib, and they should stay on it because they're doing great. You wouldn't change horses midstream. But what are they doing? Well, they're either trying to generate data of how their drug works post-alectinib, or they're saying, forget that, I'm going to become the new first-line drug. So brigatinib has a study, Alta-1L, which we'll probably read out this year. Interestingly enough, if the frequency of those pulmonary events is related to time from prior crizotinib and you go on it first, there's no prior crizotinib, so the frequency may be even lower. Lorlatinib is trying to do that versus crizotinib, that's the CROWN study, and then sartinib, that's the EXACT-3 study. So we will have potentially several drugs licensed in the first-line setting. What about osimertinib? So they did essentially the same design. So this is the FLORA study. So all of the osimertinib studies were called AURA. I don't actually know what AURA stood for, but this was the really cute acronym. It was first-line AURA, FLORA. See, cute. And so you had to have an EGFR mutation, and you were randomized to osimertinib or gefitinib or erlotinib, so one of the first-generation drugs. Here's the data. PFS by investigator assessment. Again, you can see, so you remember in our first-line setting, well, actually we can see here, so our standard of care has a median progression-free survival of about 10 months. Osimertinib has about 19 months. Now, osimertinib post, in the T790M positives, post first or second generation drugs, if you remember, has a median PFS of about 9 to 12 months. So if you do the math here, it's not looking quite as, game-changing. So the orange bar here, 60% of people get T790M, they go on to osimertinib, so you can do 0.6 times 10 months PFS. 40% go on to chemo. We know what chemo does in T790M positives from another study, so you can have 0.4 times that. And you can do the algebra. So if you went on this sequentially, your whole population would have a median progression-free survival, where are we, of about 18 months. And in the FLORA study, osimertinib from the get-go had a median PFS of 19 months. And that's why the NCCN said, okay, let's list it as a first-line option, but we're not going to list it as preferred. You didn't completely convince me. Now, that got some people very angry, and their arguments were this. Okay, so there we go. You can see alectinib on the top, preferred by the NCCN. You can see osimertinib in the box below, just listed. What about the tolerability? Well, they are different. Osimertinib is probably better tolerated. If you look at any cause AE causing discontinuation, 13 versus 18% for OSI versus first or second generation drugs. Grade 3, 18% versus 28%. The other argument that is strongly made is that whole, well, what if the patient, you can't commit on your promise to give them second-line therapy? We promised them that, don't worry, I'll put you on this first line, and then if you get T790M, I'll put it on your second line, it'll be the same. What if you can't honor that promise? And if you look in phase 3 studies, you can see the proportion of patients in EGFR mutant who get a first-line drug who go on to any kind of second-line therapy is only about 70%. It's a 30% drop-off. But the question you've got to ask before you buy into that argument is you have to remember those are international studies. Here we are in one of the most developed countries on earth. We're obsessed with following people up, doing scans. What proportion of your patients truly fall off between first and second line when they have an EGFR mutation? In my practice, I'd say 0. But tolerability and convenience, for some people, may be enough to say, I will favor this as my first-line treatment. I think if cost was a major factor, so certainly in Canada, in China, in Australia, in parts of Europe, that may be the major decision. And when these things are viewed in equipoise, they may still use sequential therapy. Okay, we're on to the second revolution. You up for it? Yeah, okay. Immuno-oncology. Is it unpersonalized medicine? Well, maybe yes, maybe no. Okay, basics. We're going to focus on PD-1 and PD-L1 initially. So the drugs bind to and block that PD-1, PD-L1 interaction between the tumor cell and an activated T cell. This is a negative checkpoint in immune activation. But that is not the immediate effector of action. This is not like giving an ALK inhibitor that interferes with an activated ALK protein. The effector is the activated T cell. And the key thing is that there are many, many more assumptions that go on between your drug binding the target and something good happening than happen in the oncogene-addicted world. let's look at where the data started. Second-line studies, largely unselected population. And you could see, and they're all listed down here, and if you have the slides, you can look at these in detail. But essentially, there were minor differences in response rate between PD-1 or PD-1 agonists and docetaxel, which was the control arm used in all of these second-line studies, but a major difference in the duration of response. An immune response is very different. It's gangbusters, and it goes on and on and on and on. So that, you can have the durations of response can last for a year and a half, more sometimes. The median progression-free survival was usually not different. The hazard ratio for progression-free survival was rarely significantly better. But all of them got a license on the basis of overall survival, and they all improved, compared to docetaxel, overall survival. Pembrolizumab improved it, atezolizumab improved it, nivolumab improved it in both squamous and non-squamous. So, again, I want you guys to think. Sometimes there are mysteries sitting right in front of us that no one has noticed. Here's the first mystery. Why is there an early-late efficacy disconnect in these studies? Why do we not have a PFS advantage, but we do have an overall survival advantage? So the first myth, I would argue, is that this is because of pseudo-progression. Pseudo-progression is the immune system goes in there, makes your cancer swell up, it looks like it's growing, and then it shrinks. So they're listed as a PFS event, but then good stuff happens later. Pseudoprogression is fantastically rare in non-small cell lung cancer. And I would say the single biggest error going out there in the community is either keeping patients who are overtly progressing on drug or not scanning them early. I saw a patient the other day, they'd had 10 months of pembrolizumab and no one had scanned them. Because I won't be able to interpret the scan. Nonsense. If the patient is losing weight, their tumor markers are going up, their symptoms are getting worse, they are progressing, and you are killing the patient. They did a study. It's the best data we've got. The FDA actually led it, and then there was a subsequent one led by atezolizumab, looking at saying, of the patients who stayed on the drug because of perceived possible pseudoprogression, what proportion of them then had the tumor shrink? At best, it was 8% of that group. Okay, that is the most optimistic estimate for pseudoprogression. The reason that number is actually less than that is only the patients that the physicians felt they were already benefiting and put them in that group. The ones who they felt were actually progressing, they took them out. If you include those in the denominator, the pseudoprogression rate is 2%. And the numbers are completely robust between the FDA analysis of Pembro and Nivo and the atezolizumab analysis. 8% if you give it your best guess. So even when you're convinced it's pseudoprogression, you're wrong 92% of the time. Or if you just don't look, like the guy I just described, he's going to be wrong 98% of the time. So the alternative explanation is that this is real progression, but something happens later. I'll give you some data in terms of what that might be in a second. Okay, what about deciding which of these multiple drugs which are now licensed in the second line you should use, assuming that they're all equivalent and there's no data otherwise? Well, only one of them, pembrolizumab, technically requires you to have PD-L1 status to give it in the second line. Frequency of administration. This slide is already out of date. Atezolizumab and pembrolizumab every 21 days, nivolumab 14 days. Not anymore. Nivolumab every 28 days. And cost, and that may well vary depending on your payer system. So this is a moving target. For a period of time, atezolizumab, even though it was the last one to be licensed, managed to say, you don't need PD-L1, you can give it every 3 weeks, and by the way, we're going to price it so it's a smidge cheaper. And it got into a lot of pathways. That may change depending on what the cost of Q28 nivolumab is. Biomarkers. I got to tell you, I have gray hair. If I didn't have gray hair, I would have it now after all of the issues with biomarkers in immunotherapy. This works to both our best and our worst instincts as investigators. One of the biomarkers that we've mostly used is PD-L1 immunohistochemistry. It's a continuous variable. Greater levels enrich for benefit, but you can never get a number that is 100% predictive of benefit or 0% predictive of benefit. So this was the oncogene. You get a driver, you get a mutation, you get a protein, you give the drug, everything's happy. All of your assumptions about testing for the gene and that they're going to benefit are very low-risk assumptions. Okay? That's what happens with immunotherapy. You have a whole bunch of mutations. They've got to change the amino acid sequence. They've got to be presented on your major histocompatibility complex. They have to be in the setting of a pro-inflammatory immune environment. You have to be using PD-1 as one of your mechanisms, if not the dominant mechanism of immune escape, and then you have to give your drug and it has to get there. Every single one of those assumptions is actually a high-risk assumption, and that's why every biomarker we've got has actually got a fairly low predictive probability. Now, the solution in the future, the obvious thing, is to reduce the risk of those assumptions, which means we're going to have to combine biomarkers, but that so far has not happened. That's another talk. Let's talk about PD-L1. So here's the nivolumab data. And again, I just want to show you, because I want you not to just absorb the information you're given. I want you to question it. Here's the data from that second-line study in squamous cancer of docetaxel versus nivolumab in the squamous population. And they're showing what happens if you do different levels of PD-L1 immunohistochemistry. And they show greater than or equal to 1%, less than 1%, greater than or equal to 5%, less than 5%, greater than or equal to 10%, less than 10%. Okay, and they show it doesn't make a difference. Right. They do the same in non-squamous. Maybe there's a little bit more of a trend of a difference, but they still say it's not that impressive. Yet pembrolizumab, so there you have this impression that you change the levels of PD-1 doesn't make a difference. Pembrolizumab, in their huge phase 1 study, which had hundreds of patients in it, the purple bars are the frequency with which the PD-L1 levels exist. The blue bars are the response rate. You can see they present it in a different way. They've done it by little silos. If your PS is proportion score, that's the percentage of cells staining. 1 to 24, you get about a 10% response rate. 25 to 49 goes up to about 20%. 50 to 74%, you're up to about 30, 40% response rate. 75 to 100%, you're pushing north of 40%. And there doesn't seem to be a ceiling. How do we reconcile these two things? One, nivolumab, PD-L1 doesn't make a difference. Pembrolizumab does make a difference. It's all how you present the data. Here's the analogy. The NBA, okay? This is actually a plot. This is a plot of the average height of NBA players, okay? But we're going to assume that height here represents PD-L1 expression. Just imagine, now this isn't actually true, but just imagine that all of the baskets are scored by the really tall people, okay? And if you are a tiny little 6'1" person, you just never get a shot at the basket, okay? And so what did Nevo do? Well, they said, look, what if we put the cut point here? The number of baskets, so we get rid of everyone who's under 6 foot tall. Oh, score in the game stays the same. What if we get rid of everyone who's under 6'4"? Score in the game stays exactly the same. Why? Because it's all being driven by the high-level stuff. That's the interpretation of when you do your analysis by just gradually shaving away stuff at the bottom. That's the wrong way to do the analysis. That's a way of proving the argument that you want to have, which is PD-L1 levels don't make a difference because you don't want to shrink your market size. Sorry, BMS, but there we go. So the thing about these biomarkers is they're completely flexible. By going up and down, you can change the amount of benefit in that population. So they're hurdles. And so it becomes fit for purpose. How much do you enrich depending on what hurdle you want to clear? So a low hurdle is if you have a trial where you're compared to placebo or salvage chemotherapy. Modest hurdle, second line versus docetaxel. Highest hurdle is versus platinum doublet chemotherapy. So if you have minimal enrichment, no PD-L1 enrichment, maximal target population, you can probably just clear low fence. If you want to beat first-line chemotherapy, you have to maximally enrich, but you're going to shrink your target population. Okay? Go back to that Pembro data. Not the basketball players. Here's the Pembro data. So you look at this and you go, well, why didn't they choose a proportion score of 75%? Well, the reason is because they only needed to beat first-line chemotherapy. They needed a response rate about 40%, and so they chose the 50% one. It was fit for purpose. Okay. And you have 10 minutes to go. I've got to get through this. Okay, so here we go. So here's 024, first-line study, enriched to about 30% of the population that had that proportion score of 50%, and pembrolizumab beat platinum doublet chemotherapy. There we go. Median PFS, 10 months versus 6 months, hazard ratio significant. Also improved overall survival, and response rate. The overall survival is actually really interesting. Because some of these drugs have been licensed, 60% of the people crossed over, yet it still has an overall survival advantage. And then you start to get really interested. Why? I mean, we haven't shown an overall survival advantage for EGFR TKIs yet after 10 years of trying. So I think the assumption is that getting these drugs in earlier, in the right people, is better. And the assumption is that if you have prior chemotherapy, then somehow you are beating up your immune system. Or the stuff that you kill off with chemotherapy is the most mutated, ugly-looking cell, so your cancer looks a bit more like vanilla ice at the end of it, so it's less immunogenic. And certainly that explanation could explain how you, in the first-line study, you have a greater effect on response rate, PFS, and overall survival. We can see that clearly the PFS got better. This is pembrolizumab in that big phase 1 study. Same proportion score, same drug, but if you go in a treatment-naive setting, your PFS was 12 months. If you go in the previously treated setting, your PFS was 6 months. So it kind of fits with the idea that your immune system is part of what gets beaten up by prior chemotherapy, so getting it in earlier is better. This is the other interesting thing about effect on subsequent therapies. Even though the drug has stopped, which is really interesting, there have been at least 3 different reports of salvage chemotherapies having much higher than expected response rates. So here, this in this little bar graph down here, this is last chemotherapy before immunotherapy in the yellow bar, and then the salvage chemotherapy after immunotherapy in the blue bar. And the blue bar is always higher. And some of them are astonishing. They're getting like 30% response rates to single-agent gemcitabine. This is actually a study from MD Anderson. Same thing, 39% response rate to third-line standard of care chemotherapy, even in patients who didn't respond to the immunotherapy. And the idea is that maybe the drug is in there, it's still doing something, and the quality of the chemotherapy can vary in terms of how much it promotes an immune reaction. So not all chemotherapies are equally immunogenic. Okay, my last mystery is, you remember we talked about the early-late PFS overall survival disconnect? That doesn't happen in Keynote 024, that first-line study. PFS hazard ratio 0.5, overall survival hazard ratio 0.6. Why? Well, it can't be pseudo-progression rate is higher in second line, and we've already poo-pooed pseudo-progression. There's fewer responders in the second line. I think, again, the idea is that maybe that chemotherapy is somehow trashing your ability to manifest a response. But if you go on the immunotherapy, during that period of time, whether you're responding to the immunotherapy or not, your immune system may be recovering because it's not on chemo. And maybe that's why it can manifest stuff later and you get this PFS overall survival disconnect. In the treatment-naive setting, you're not beaten up, so the PFS and overall survival look different, or maybe just the data's immature. So now we have this box which is pulled out separate to our oncogene addicted. We have PD-L1 at 50%. But now, you've got to ask yourself, if you're not in that 50%, all of those decisions that we previously talked about, second-line immunotherapy, are they still going to be valid? Data becomes redundant very, very quickly. Remember that all those second-line studies versus docetaxel included people with high PD-L1. And now if they get pembrolizumab monotherapy, that data that you're trying to interpret to say, oh, this is your chance of benefiting from second-line atezolizumab. If you didn't, if you're in the lower, we don't know what that means. What about the new thing? Don't bother pre-selecting. Give everybody chemotherapy, immunotherapy. One answer for everybody. Keynote 21G was the small phase 2 study that astonishingly got approved by the FDA. You had to be EGFR and ALK negative. You were randomized to pembrolizumab in combination with carbo-pem or carbo-pem. It was obviously for non-squamous. Progression-free survival was improved with a hazard ratio of 0.5. But the question you have to ask here is, who is benefiting from what? If you look at the response rate, I love the fact that we show data and we see what we want. So they show this, and they go, look, 80% response rate with the chemo immuno, 40% with the chemo. That's fantastic. Look, if you look in the less than 1%, it's 13% versus 62%. That's fantastic. But hold on, if they had greater than 50%, shouldn't they be getting pembro monotherapy? Isn't that the wrong control arm? So I can't interpret this. And they have independent data sets. The other thing about this is, look at that big group of people who have PD-L1 1 to 49%. Oh, there we go. 1 to 49%. Response rate goes the other way. It's a little inconvenient. So Keynote 189 is the phase 3 study that we will hear about in about 2 weeks' time at AACR. And we know from a press release, research by press release, that it met its dual primary endpoints of overall survival and progression-free survival. And when we see the data, we're going to have to ask who is benefiting and from what. Okay? You're going to have to pin them down and say, show me the PD-L1 scores of these patients. In terms of that issue, in terms of the high PD-L1, how does that stack up to comparing to Pembro alone, which isn't in that 189 study? There's actually a SWOG study called Insignia which will attempt to answer that. But that is not the direction that pharma is particularly interested in, but it needs to be done. What about IO-IO combinations? Well, there is our terminally insecure T cell. It doesn't take very much to put him off asking girl to the dance. We know about PD-1, but he has all these other insecurities. Okay, all these other checkpoints that can put him off. We're just going to look at one, CTLA-4. Checkmate 227. Nivo alone versus platinum chemotherapy, or Nivo-IPI, and then they stratified by PD-L1 level. Now the press release. This will also be shown at AACR. Now, I don't know if there's any statisticians in the audience, I don't know how many co-primary endpoints you can have before it becomes a little ridiculous. But they had modified it, presumably because they'd had some negative studies, now looking at tumor mutation burden, another way of enriching for those who might benefit. And using their assay, which is about 45% of the population, they issued a statement saying that Ipi-Nivo beat first-line chemo in the high tumor mutation burden, with the statement regardless of PD-L1 expression. This is a very difficult press release to know what to make of it. Does this tell me that Nivo alone didn't beat chemo? Don't know. Because tumor mutation burden would also enrich for benefit from Nivo alone. Regardless of PD-L1 expression, does that mean even if you had low or high, you beat chemotherapy, or you beat chemotherapy and your efficacy was the same? I don't know. So we are going to have to see what that shows. Because increasingly we are getting the situation where a positive trial result are not all equal. We are going to have to ask ourselves the question, who is benefiting from what? Okay, final few minutes. Where are these revolutions clashing into each other? PD-L1 and oncogene-addicted subtypes. Every single one of the studies showed, even compared to crappy docetaxel was better than immunotherapy if you had an EGFR mutation. I mean, that's a pretty low hurdle to get over, right? And that's why the NCCN now says, you do your diagnostic testing, PD-L1 and oncogene, and if you have an actionable oncogene, you prioritize that regardless of the PD-L1 score. So they're separate populations. The worst thing would be everyone gets chemoimmunity and nobody tests for another EGFR or ALK in the future of mankind, and that would be a complete disaster. Why doesn't PD-L1 predict the same? Because PD-L1 can go up for reasons other than being induced by your immune system, and sometimes it's downstream of an oncogene. That's called intrinsic induction, and it means absolutely nothing. So if you have an ALK-positive patient with 90% PD-L1, they need an ALK inhibitor. Internationally, the immunotherapy response rate in ALK-positive lung cancer is 0%. Internationally, I have never seen a single case anywhere in the world of an ALK-positive patient responding to immunotherapy. I'm happy to, I'll give you $1 if you'll show me one case. Okay? 60% of ALK-positive patients in the community get immunotherapy. Something's going wrong. So, to summarize, targeted therapy is pushing forward in multiple oncogenic subtypes, adapting to changes in the body and brain. Broadening the coverage of resistance mechanisms is pushing for a first-line license, so alectinib would be a great example of that. Tolerability, cost, and if clearly better than a sequential approach are key considerations. Immunotherapy is not a panacea. Not knowing who it works in is not the same thing it works in everybody. Enrichment methods are variably used and abused. Second-line data is increasingly debatably applicable as we pull high PD-L1 out into the first-line setting. The phase 3 data on carbopen-pembro, that's Keynote 189, is awaited, as is the CTLA-4 PD-1 combination data. Who is benefiting from what has to keep being asked? An oncogenic driver should be prioritized over the PD-L1 score. Thank you. If I have seconds left, I am happy to take a question. Okay. I have 1 minute left. I have 1 minute for questions.
If you have someone on a PD-L1 antibody, when do you rescan?
Say again? Oh, so you can get rapid responses. I scan after 6 weeks.
After 6 weeks. So if it appears that there's possible progression or pseudo-progression
Yeah.
in 6 weeks, but they're clinically stable, then you just repeat the scan in 4 weeks?
So you've got to ask yourself, the question is, not just look at the scan, but look at the patient. Is the patient feeling better? If they feel the same, they're probably not benefiting. If you believe in serum tumor markers, if they're going up, they're probably not benefiting. So I think you have to use clinical skills, and you have to know the numbers. The numbers are, the vast majority of times, they're not benefiting. But yes, I think if you're suspicious, then you would try and do an early rescan in the kind of 3 weeks, 4 weeks kind of time frame. Do you want me to wrap it up? Okay, I got to wrap it up. Thank you.